Okay, so another installment of the BPH talk. I've given this talk lots of times, and maybe some people even will see it more than once. You're going to hear me plug my website a lot on this site because my website is probably an even closer representation of kind of what I do and how I do it. So please do go to my website, dcurology.net, to sort of kind of see my own spin on some of these things. But we're going to follow these slides along. Today we're going to talk about BPH. So what's BPH? Benign prostatic hyperplasia. And the way I explain that is that's just sort of a part of getting older for every man. And it's these lectures get more and more, I'm not going to say dear to my heart because I have the same problem. I get up at night now. I'm about to be 58. I am kind of this guy here in this picture. And so I can very much commiserate with this, but let's kind of demystify some of this. This is a very simple talk, really. This is a simple issue, but it's a really annoying issue, and there's really easy things that we can do for it. So BPH, which means your prostate grows as you get older. Okay, your prostate grows as you get older. So that's me. And with this slide, I should always redo this slide, but this slide really should have the most important thing is my website. I take a lot of pride in it. I get probably 35,000 hits a month on it. It's very educational, and certainly I think I know I educate a lot of people across the country with my site that don't necessarily see me. So please do take advantage of that and look at lots of different topics and not just BPH if you wish. So we're going to talk about basically what's the prostate. People really, I mean, there's no reason for a man to really know what their prostate is. So I'll teach you what that is. What is this process of your prostate getting bigger as you get older? Why does it happen? Well, I'll just, spoiler alert, we don't really know why it happens, but it very much is just a part of getting older. And then if it annoys you, because you don't have to do anything about it if it doesn't bother you or if it's not causing trouble, but if it annoys you, what can we do to help you? And there's a lot that we can do to help you. So, what is the prostate? The prostate is a gland, and any organ in your body that is a gland is basically something that makes some kind of fluid. Okay. Now, the prostate doesn't make semen, it makes prostatic fluid, and we're not really even sure what that does, to be honest with you. One thing that's in that prostatic fluid is this substance called PSA. We'll talk about that a little bit. That's a screening test for prostate cancer. So there is a little overlap in that discussion, but we're not going to talk too much about PSA tonight. But in essence, what you can see here is that it's what I call a fancy junction valve, a fancy plumbing piece. Here's your bladder. You have to urinate through your prostate. So it's like a donut or a bagel that you urinate through. And also what connects into it, as pictured here, is your seminal vesicle. So that's the thing that makes semen. That's what makes semen, not your testicle. And it's a duct that goes through the prostate. One of the amazing things about the anatomy is here's a system here, your urethra, your lower urinary tract. Here's a system that we're using for two purposes. We use that same system to urinate and to ejaculate, which is pretty incredible if you think about it. And the thing that allows for that is this on-off switch, this junction valve called the prostate. And it starts to grow. I mean, we know it's a famous study where they looked at Vietnam veterans and they could see that it starts to kind of grow when you start to have a testosterone surge, but really it starts to grow late 40s or so, and men will start to notice the difference in their urination in their 50s. So that's normal. PSA, by the way, is a substance that all we know that it does is it liquefies semen. So that's important because when you ejaculate, it has to liquefy so that it can get where it wants to go in a woman's uterus and fallopian tubes. But other than that, we're not really sure what the prostate does, but it causes lots of trouble. And the main trouble, the most common trouble that it causes, because most guys, if you're an older guy, if you're getting in your late 50s and you're not having any trouble, you're lucky. But otherwise, it's not a mystery. It's just a part of getting older. It's like gray hair. So the most common thing it causes is enlarged prostate. This term prostatitis is a very old-fashioned term. We have a much more PC and 2025 term called pelvic floor problems. We used to blame everything in a man on their prostate, any irritative symptoms. If it was kind of like a definition of man with lower urinary tract symptoms with no identifiable problem, we would call it prostatitis. And it lent itself to think that we had infections and used antibiotics when we didn't need to. So we're not going to talk about that, but that's another topic for another day. And of course, the prostate can get prostate cancer in it. We're not going to talk about that much today, other than the fact that PSA, which is a screening test for prostate cancer, also tends to go up as your prostate grows as you get older. So there's a lot of experience that goes into differentiating a PSA pattern that looks more like enlarged prostate versus a PSA pattern that looks like prostate cancer. But otherwise, we're not going to talk too much about prostate cancer and PSA tonight. We're going to talk about the most common problem, the inevitable problem of your prostate growing and it's blocking your bladder. It keeps showing this guy. I don't know how old this guy is. I don't know if he's in his 50s, to be honest with you, but I guess he has some gray hair. But I guess that's when it starts. So we've already talked basically what you need to know. What is BPH? It's just that it's benign. The B stands for benign. So we're going to talk about what I call the 3 visits. There's not a slide, but I'm going to make sure I get it in there. There's basically 3 situations where people will come to see the urologist when they're dealing with this problem, and we'll get into that. But the first one tends to be, and if we look at this graph, I can't stress it enough, where it says non-cancerous. People will notice that there's a change to their urination, and then they immediately, in the back of their mind, they may not even mention it in the visit, they wonder if that could be from prostate cancer. That's a very rare effect of prostate cancer. So that's important for you to know. It's a benign process. It grows as you get older. It blocks your bladder. We don't exactly know why it happens. But it's something that is a ubiquitous problem as you get older. But that's what BPH is. And this slide basically talks to what I already have talked about. And this is the first visit that people come to see us for. They'll notice a change. They won't maybe mention that they're worried about prostate cancer, and I'll just kind of blurt it out there. Again, when you're in your 50s and you start to notice that change, it's not typically from cancer. That's just you get a PSA, you show that there's nothing suspicious, and we don't worry about it. And I would say that there's a lot of men that come in with that concern, and they're not looking for treatment per se. They're looking for reassurance. So that first visit that people come, usually in the early 50s, is for reassurance that what's going on is normal and not from cancer. This is just an obvious slide. It's not a great slide. It just gives you a sense that if you have a prostate that starts growing on you, it blocks your bladder and you tend to retain urine. The bladder is a muscle and it has to squeeze to get the urine out. And if there's an obstruction to outflow, just like your heart, if you have a bad aortic valve, it gets hypertrophied. The bladder gets hypertrophied. If it gets hypertrophied, it tends to get irritable. You tend to have urgency. You tend to have to go more frequently. This is what causes all this stuff. And this point down here is an important point, which is people will say, but my internist did a rectal exam and told me I didn't have a big prostate. And it's not necessarily, it does correlate somewhat, but it is not necessarily the size of your prostate that determines if you're obstructed or if your bladder is not happy with things. It's whether or not the donut hole or the bagel hole is crowding things out such that it's making your bladder irritable and unhappy. So there's plenty of people with a huge prostate that for whatever reason, they don't really have a big problem with urination. They're lucky. They have a great bladder. There's people with a smaller prostate that can have a huge problem if for whatever reason the prostate's growing inward and blocking them. So just because you don't have a huge prostate doesn't mean you don't have BPH. These are all the symptoms. Maybe a lot of you, these are all things that come with age. I'm certainly having them. My flow is not as good as it used to be. I have more urgency. I have to kind of sit there and wait and let it dribble out. These are all things I didn't deal with in my 20s and 30s and even my 40s. And the worst case scenario is when suddenly you get to a place where all of a sudden you can't urinate. That's kind of the end of the line of this whole thing that we're trying to avoid. And that person goes to an ER and gets a catheter, et cetera. So all of these things. The main thing that people will complain about is that they get up a lot at night to urinate. So people can deal with a weak flow. People can deal with they start and stop, they dribble, but they don't like getting up many times at night. So that's probably the number one reason that people will say, now I'm really bothered. now I want to do something about it. That, and I suddenly am peeing on myself sometimes, or I can't wait in my car and have a bottle in my car, or these kinds of things. This is when you move on to the second visit. This is an obvious slide just to say BPH stinks and it sucks and it can be really annoying. And the bottom line, who can get BPH? Any man gets BPH. So this is a very common problem. It's not that everyone gets to the point where they seek treatment. It's not that everyone gets to the point where they want to be treated. But what I'm trying to do in my practice is I'm trying to, at least if they're going to get treated, they get treated. They don't have fear of the unknown. So this is where my website, dcurology.net, comes in, which is let me educate you so you at least don't not seek treatment because you're confusing treatment with something that is going to have all these side effects and problems, which most BPH treatments don't have. I don't really know if obesity or body mass index necessarily increases the risk of BPH, but it does increase the risk of other urinary symptoms. So how do we diagnose this? Again, I already told you that, yes, I can do a rectal exam and say you have a really big prostate, but again, that doesn't necessarily correlate. How we diagnose this, number one, is you say, I'm not happy with my urination. And what we rely on mostly, and anyone who's seen us in the office has filled one of these surveys out, is this score called the International Prostate Symptom Score, the IPSS score. And this was developed, it has to be 25 years ago now, but it's one of the most powerful surveys in medicine. It seems very subjective, how many times you get up at night, how happy are you with your urination, but it completely correlates really with, where you are. I can tell which visit you're at. Are you at the reassurance visit? Are you at that second visit, which is the treatment visit? You say, okay, I know I don't have prostate cancer, but the treatment visit is now I'm annoyed where I'm ready to be treated. We'll talk about what initial treatment is, and we'll get to what the third treatment is too. The third visit is too, at least in my practice. But this survey is incredibly valuable to us. It tells us in 2 seconds what you're complaining of. There are a lot of tests that I can do, frankly. There's something called a Euroflow. There's something called a Eurocuff. I don't do a lot of these. I know that I would make more money if I did those things, but I don't tend to test people unless they're going to make much of a difference. Those are a little bit, I consider, money-making ventures. A patient can tell me if they're bothered with their flow, and they can tell me if they're bothered with how they urinate. The digital rectal exam is not a great way to establish whether you have this trouble because the question is whether you're obstructed again. The PSA is not a great way to determine if you have this, but there, as we've discussed, there is this overlap between if your prostate's getting bigger, a big benign prostate makes a higher PSA. So there's some overlap there. Just know that, but it's mostly talking to you and then seeing what your individual symptoms are with a survey. And that's going to tell me in 2 seconds, how bothered are you? What are your complaints? And I can tell in that survey, do you want to be treated? So treatment options. So number one, again, unless you're hurting yourself, treatment options are not mandatory. I feel as if I pride myself on I tell people what the options are. I tell them I'm ready to do that when you are. But this is not a cancer thing. This is, we're going to make sure in the office that you're not having a big stretched out bladder and you're going to hurt it. That's something where I might say to you, hey, maybe we should do something about this before you have a stretched out bladder and you'll be sorry. I'm going to tell you if there's other problems going on, but the 90-something% of people, there are no other problems. It's a function of, are you annoyed such that you're ready to ask for treatment? And so this is the importance of this. So I demystify what the treatments are. And the first treatments are easy. I mean, after that initial visit, which is the reassurance visit, most people are going to say, I'm good. And you know what? And I very much know this myself. I work out almost every day. I do triathlons. I just got off the bike and just stepped into this talk. I just rode home in this weather. And I know I'm going to be dehydrated. And I went running this morning and I know I'm going to start drinking a lot of fluid. And I know if I start drinking a lot of fluid right before I go to bed, I'm going to pay for it. I know that. So maybe what I'm going to do is drink a lot right when I'm done with this talk, and I'm going to stop pounding fluids right before I go to bed. So that's what people do. Watchful waiting just means I'm not going to be treated now. I'll just see if it gets worse. I personally, right now, I'm not being treated. I'm seeing if it gets worse. But the one thing you need to know is it always gets worse. I know mine's going to get worse. And when it comes to that, I'll go ahead and, I've had a PSA. I know it's okay. When it comes to, I'll wait to see what triggers me to say I want to be treated. Um, Kegel exercises don't really do anything for you. Bladder retraining, this is my opinions. I don't think they have much role in that. Um, all of us have gotten to the point where we say, "Oh my God, I'm on the New Jersey Turnpike and I have to go real bad, and it's 20 miles to the next exit." And so Kegel exercise just means, if you squeeze real hard, like you're going to stop peeing, it can kind of extinct that feeling of having to urinate for a few minutes. It's not really the real answer here. But again, it's all about when you're ready, I'm ready to help you. My own story for everybody has this point. Sometimes we'll get into these academic discussions of, yeah, but you need to tell me what to do. And I can't tell a person what to do. It has to do with how bothered you are, and are you willing to start therapy? And the first therapy is medications. That's what we're going to talk about next. In my practice, I strongly believe the first step is medications. It's not talking you into some minimally invasive procedure as an alternative to medication. It's try the medication, see what you think about that. And if either you have side effects or you don't like it, or more commonly, it doesn't work, then we'll talk about the next step. My style is sort of a stepwise progression. These days, we very commonly see in really, really big groups, maybe groups that are owned by private equity, and there's more of like a templated, profit thing built into that. We will see sort of the creeping in of trying to say, well, you can either do medicine or a procedure. I don't agree with that. So I'm not going to call, frankly, the Rezūm, which is what I do, which is an office procedure, or the UroLift, which should also be an office procedure. I don't consider them first line. I consider them second line. I consider medications first line. You may only try it for a month and say, I don't like it, but all my patients try medication. We'll get to the surgical procedures, but the progression is reassure, you tell me when you're ready. And I was going to get to the point of, with every man, it's different when you're ready. Is it you're an attorney and you're a litigator and you can't make it through a trial and it's embarrassing? You have to actually ask for a recess to go to the bathroom. Those people will ask. I know myself, I've been socializing, drinking, doing whatever, and I have to urinate. Okay, I go urinate. Then I come back and, and in 30 minutes, feel like I have to go again and urgently. Well, I don't want to embarrass myself, so I try to hold it. When I get to the bathroom, I'm like, oh my God, there's a few spots in my pants, that kind of thing. If that kept happening to me, that would be the break point. So it's always up to the patient, in my opinion. So we're going to get to all of these things. Just know that the first line are medications. And the first line here, and this slide is pretty strong against herbal things and these kinds of things, but they're just such a part of our society that I don't foo-foo these things. If someone says I'm ready to, it's funny that the patient mentality in the whole herbal industry has people thinking that that's not necessarily treatment. That's something shy of treatment. And I don't consider it that. I'd say, well, if that's what you're willing to do instead of the medicines that actually work, then that's treatment and go for it. They're not going to hurt you. The most famous one in that category is saw palmetto. Back a while ago, there used to be something called super beta prostate by Joe Theismann. And now there's other prostate things. And I always say, go for it, give it a try. But to me, I consider that means you're being treated. That's the first step. So let's call that like step 1/2. We already talked about watchful waiting, which is just wait and see. That's what I'm doing. See if it gets worse. And then we're going to talk about medications. So if you say, all right, I want to be treated, I'm not interested in these herbal things, or I've already done the herbal things and they didn't really work. And really, the thing about herbal things is what I tell patients, I don't really think they're going to hurt you. I mean, if they were damaging or they were going to make you sick or harm you in some way, they would still be regulated by the government. But the herbal things are not regulated as drugs in our society. They are regulated as food in our society. So as long as it doesn't kill you, they can sell you whatever they want. There's no claim that it does anything. They have to actually be very careful that there is no claim that it does anything. And I always tell patients, if you think that there's some herbal company that's got this magic ingredient that these big, massive, evil drug companies that are unbelievably powerful and are unbelievably wealthy have not already tested, they have not already looked into, it's a very short-sighted understanding of the situation. They have tested those things. They don't work better than placebo. That's why they haven't put a hydrogen on it and patented it and sold it. Okay. Again, not a knock against the herbal industry, but when someone's like, okay, now I'm really ready to be treated, we dive into medicine. The medicines that are the typical ones that you'll start with are called alpha blockers. That's a certain muscular receptor, alpha blockers. And examples of that, the most common ones, the trade names would be Flomax or Uroxetrol. That's a common one. And there's Rapaflo. That kind of came and went. No one really uses that much generically because it very much causes you to not ejaculate semen. The earliest ones were called Hytrin and Cardura. So alpha blockers, they do work. They're the front lines. As you get older and older in the chain of them, they get more and more selective to the prostate area, the pelvic floor muscle, the base of your bladder. So there's fewer side effects. The one I use most commonly is alfuzacin. Sometimes alfuzacin, if you're on certain cardiac medications, can't be used. And most people, their go-to has been something historically called Flomax, which is otherwise known as tamsulosin. So alpha blockers work. They take a couple weeks to know what's up. You take them and you see if you have side effects. They're specific to each drug. Flomax can have nasal stuffiness. Sometimes they make you dizzy. Sometimes they don't make you feel good. So that would be one reason to say I tried them and they're no good for me particularly. But this is kind of where we start, alpha blockers. The other most common category, and they're less common now than they used to be, are called 5-alpha reductase inhibitors. You may have heard these as Proscar. Most people have not heard the word Abodart. These are the generic names finasteride or dutasteride. Proscar or finasteride was the first enlarged prostate medication. It came out when I was a resident. When I was a resident, everyone just had a surgery. None of these minimally invasive things happened. We're going to talk about something called a TURP, and that was the most common operation in America. If you had this problem, you had a TURP. It was that simple. That would have been fun for the surgeon. When Proscar came out, these are drugs that block a certain type of testosterone, so it makes your prostate shrink. It sounds perfect, right? Your prostate grows as you get older. We're going to make it shrink, and it's going to work great. The problem is it makes the prostate shrink, but it doesn't make the donut hole bigger or the bagel hole bigger. So it really doesn't work that well in terms of your symptoms unless you have a huge prostate. And we can talk about that as a subset of patients. In fact, this was one of these famous, Harvard Business School models where one of the alpha blockers did a head-to-head comparison with Proscar, and it showed that Proscar didn't work any better than sugar pill, and it went from $1 billion drug to overnight it didn't work anymore. So they started marketing it for hair loss called Propecia. And that's an important thing because a lot of people do take it for hair loss. Yeah, you just have to know if you take it for hair loss, that it lowers your PSA by 50%. So that's always important to tell your doctor, I'm on this. So when you go over my PSA, it's a way, it's important to know that. But I don't use many 5-alpha reductase inhibitors because frankly, they just don't work. And we're going to talk about my style in a second. There's not a slide in this, and I always forget to bring it up, on a third drug that's out there. It's not that common anymore. It used to be more common, which is daily Cialis. Daily Cialis, which is the erection medication. But if you take it daily at a 5-milligram pill, it does help you urinate some. It's not quite as good as these other drugs. It's not quite as good as the alpha blockers, but it's a legitimate drug for enlarged prostate. No one really uses it anymore. It was very popular in the days that Cialis itself or Viagra itself was a complete ripoff. It was $60 a pill. It was just absolutely crazy. And because there was FDA approval with Cialis for this finding that it helps you urinate, it was a way kind of for men to get their erection drugs paid for by insurance. So that's where it kind of had its inroads in this world. Now that those drugs are super cheap, I don't know anybody that just starts people on daily Cialis for this problem. We usually separate the two issues. You take Cialis or Viagra at a higher dose if you want to, take a 5-alpha reductase. But it is a legitimate drug. It is FDA approved for BPH, daily Cialis, not Viagra, daily Cialis. I always forget that, and I'm glad that I remembered it now. So those are all the medicines. So let's talk about in my practice what happens. So I'm going to say, let's start an alpha blocker. I'm going to let's start alfuzosin. You're starting to have symptoms. Your IPSS survey has told us that you're bothered and you want help with this. So we're going to start a medicine and we're going to have you take that for a month. And we always say, well, there's really 3 outcomes to this. It can work really well, and it's a temporary reprieve. It's not going to solve, it's not fixing your problem. It's just relaxing the base of your bladder and your prostate and letting it open up a bit so it can kind of empty better, and it can help the symptoms considerably. But classically with medicine, there's going to be a reprieve, and then the prostate keeps growing, and eventually you'll grow out of that efficacy. But that's not a reason not to stay on it or take it. That's a reason to take it. But the question is, what happens when there's that patient that says, I've taken alfuzosin and I'm very happy with it, but now I'm back 3 years later because the symptoms have gotten worse again and I'm right back where I started? That's where my approach is a little bit different than some others. It's less aggressive than some. Some of these private equity groups would kind of talk you into a procedure up front, but it's a little more informational and aggressive than others. And meaning, what I tell patients when they come back, when that first medicine stops working, is I say they have a decision to make. It's where I rely on my website. It's where I ask them to watch my recorded webinar and read about the other options. And this is where I usually break out the analogy of the bathroom sink. So I'm going to tell it to you now. This is not a hard to understand problem. If we're a homeowner or a long-term renter, we all have a bathroom sink that at some point, especially if we're married and our spouse's hair goes down the sink, there's always going to come a point where it doesn't drain like it did when it was brand new. And it's no big deal. You live with it. Who cares? There's always going to be a point where you say, I need to fix my sink. It's annoying now. For me, it's when my shavings it goes down so slowly that it won't just go down and I have to come back and like wash them down and do all this stuff because it's draining slowly. Everyone's got a different threshold to where they'd say they need to do something with their sink. That's just like first noticing the problem and being reassured. And now I want to do something. I want to do something about my sink. And what do? You wouldn't go and hire a plumber. You would just get Drano the next time you're at the supermarket. The Drano is the first medicine. And sometimes Drano works great, and sometimes it doesn't, and sometimes it works, but you got to keep putting it in. I find this to be a perfect analogy. But what happens if you keep putting the Drano in every month or every 2 weeks and you're good, but then it stops working? What would you do then? Well, when someone comes back to me and says, my alfuzosin didn't work, the answer is, okay, well, if Drano is not working anymore, what would you do at home? Now, if you say, well, why don't you give me 2 alfuzosins? You can try that, but that's like saying, I'm going to pour the whole bottle of Drano in my sink. If the recommended dose doesn't work, the whole bottle may work a tiny bit better, but it's not going to work that much better. You're really just delaying the inevitable. So I don't have a lot of patients that go on double alfuzosin because they tend to then see, wow, there's all these easy office procedures we could do. And if you say, well, why don't we try a second medicine? What if we try a 5-alpha reductase inhibitor now? That's like saying, well, why don't I just I'm going to do Drano and liquid plumber to get this going. At some point, it kind of becomes ridiculous because you have people that are on double alfuzosin and liquid and another drug and an herbal drug, and you have to wonder, why are you doing that? You must have fear of the unknown as to what the next step is. And the next step is very simple. I'm going to call them office procedures. In my analogy, it would be like saying, well, now I'm going to go to Home Depot and I'm going to get like the better liquid plumber that's pure sulfuric acid. Or I'm going to get one of those little snake jobs that I can do myself. No big deal. That's an office procedure. And if we'll finish with this analogy, but if you take it all the way to, well, now I'm going to go beyond that, that's calling the plumber. And I'm the plumber. That's the surgeon. That's an operation. That's called a TURP. So it's just like the sink. Drano, go to Home Depot and get something easy, call the plumber. But if you want to stave off the Home Depot thing, you can try other forms of Drano, but it's not typically going to work. So that's when I really say, go to my website, see if you're interested in office procedure, and you let me know. That's maybe some of you have heard that, no pressure, but frankly, that's the logical thing once the first drug fails. Now, every group tends to have its own go-to in terms of their minimally invasive treatment for this, the next step. And I am a really big believer in it should be a very easy next step, just like going to Home Depot and getting the snake. It's not what we necessarily see in big, huge practices or in the community right now. And I'm going to talk about some procedures here a little bit out of line, but out of order because the slides are out of order. What I tend to have relied on is something called a Rezūm. That's the procedure I do. I did 2 of them today. And to me, that's what I would do in my practice if someone said, hey, what's the next step after this medicine stops working? It tends to be the Rezūm. Before the Rezūm, there was a predecessor procedure to the Rezūm called a tuna. I did hundreds and hundreds of those. That used to be my go-to. I think the Rezūm works a little better. It's much faster. I figured out how to numb people so they don't feel anything. And so this is my go-to. And so what is it? It is not cutting anything. Remember, the idea is it's a clogged sink, right? It's the donut hole or the bagel hole is closed down and you have a clogged sink. So what it's doing is it's heating the tissue under the surface in the bagel hole so that it kind of kills that tissue and your body resorbs it so that it opens up over time. So that means the effect is somewhat delayed. It takes a month or two. It doesn't shrink the whole prostate. I like to think of it as it shrinks the donut hole tissue so it opens up some. It's not going to be as wide open as a surgical procedure where I shave all the tissue out. But since all we're trying to really do is lower the workload to the bladder so that the bladder is happy again, a lot of times that's enough obstruction relief to make the bladder happy again. Okay. So that's the Rezūm. And if you let's go dive into it in much greater detail on my website. I'm going to refer to you at dcurology.net. There's very little that goes wrong with the Rezūm. You do have to have a catheter for a few days. So patients come into my office, I numb their prostate, then I look in with a scope. I would have already looked in the office as a screening test to make sure you're a good candidate. Generally, I'm looking for you to at least have an 80% to 85% success rate with this based on your anatomy. Otherwise, I might recommend something else. And then you remember, I'm not pressuring people to do this. I'm only doing this to people that are saying, I'm really annoyed. It's time to do something else. So it's going to be harder to urinate in the first few days if I just kind of heated your prostate. So you have to have that catheter. The 2 patients today will have had it done. And then what they'll do is they'll take their catheters out themselves on Friday morning early, and then they'll see my nurse practitioner later in the day just to make sure everything is okay. And then they'll stay on their medicines that they were on, that same Drano, and then they'll just wait. They'll go back to the person they were at first, a little harder to urinate over the weekend, and then it'll just slowly get better and better and better and better. And we usually see them at 3 months because at that point there's full effect. And it is pretty amazing. If it works, they're going to say, my God, this was fantastic. Problem solved. So an important point with procedures is to understand that the barometer of success is nothing like the barometer of success for medicines. Medicines work a little, usually. It's not dramatic. They work actually only a little bit better than placebo, to be honest with you. But the success in the procedure world is you say, I'm off medicine. I don't have a problem anymore. This was fantastic. Rezūm gets you there on average about 83% of the time, not 95%, but it only takes me about 2 minutes to do a Rezūm. It's pretty easy to do. So I have a very low threshold to do it. As long as you've tried medicine first, in my opinion, you should at least be able. You could try medicine and say I have side effects. I don't want to do it, or I just don't want to be on pills, but I still want you to try it. To me, the only real downside of a Rezūm is there's about a 20% chance that if you have the Rezūm, that you'll shoot less semen when you ejaculate. So it's not necessarily, I've never really, if it has any effect on your erections, it means you already have trouble to begin with, and it tends to be transient. That's a very low risk of leaking urine or being incontinent afterwards, but a significant risk, 20% or at least, of hey, I have an erection, I have an orgasm, but I don't shoot much semen afterwards. That may be the cost of success. And usually if that happens, the procedure worked, to be honest with you. So anyway, that's Rezūm. And so let's see what the next slides are. I guess I'm going to press this movie button. Let's see if it works. Okay.
Rezūm water vapor therapy is a non-surgical treatment for BPH. Rezūm uses the natural energy found in steam to shrink the prostate.
I guess this is a commercial.
In just seconds, this precise technology destroys enlarged prostate tissue while minimizing any effect on surrounding tissue. Rezūm is a potential alternative to drug therapy, permanent implants, and surgery. It preserves sexual and urinary functions, and it's clinically proven to safely and effectively reduce BPH symptoms. Patient center. You quickly return to normal, affordable life.
All right, so I'm going to go past that because it looks too much like a commercial. But let me see if I can. Okay, I've moved beyond it. I'm going to skip this. This is just a guy saying, yes, Rezūm is excellent and it worked for him and it could work for you. So that's enough about Rezūm. Again, if you really want the deep dive, I'd rather it be less of a marketing thing like that and more just go to my site. It's extremely detailed if you're at all interested. The second most common procedure, and it's gotten less and less and less common, but there was an explosion of this. This is owned by a private equity company. It was super marketed, which is called the UroLift. No one calls it the prostatic urethral lift. And this was also designed to be what I call an office procedure. And these procedures, to me, if you're going to do them, they should be done in the office. The medical economics of big, huge urology groups now is that generally they do all these things in their own surgery center for medical economics reasons. But the UroLift is a little different than the Rezūm in the sense of the Rezūm is going to heat that tissue and ablate it and let your body absorb it and see what happens. The UroLift are actual sutures that are fired through the side of your prostate, and they open like grappling hooks, like the Batman grappling hook, and then it sort of cinches open. So it's a mechanical pulling open of your prostate. And I'm not going to lie to you, it's very lucrative. And its main push was to be offered as an alternative to medication. So its main thing was, hey, we could do this or we could do medication. I don't really agree with that. The UroLift was something that really burst on the scene, and a lot of groups just really embraced it. And I think a lot of groups don't embrace it like they used to. The results were not, I think, what they were billed as. Its main marketing point is that it doesn't mess with how much semen you ejaculate. So that was its big thing. I must say that in my own practice, I haven't found that to be an enormous hindrance for people. People would like to keep how much semen they ejaculate, but one of the major side effects of those alpha blockers is that it tends to affect that. So most of the men I'm doing procedures on already don't do that well with this. We're seeing an advent of other procedures that are lucrative that have been embraced by the huge private equity owned groups, and we'll talk about them. And so these are done less and less in those scenarios, but it's a legitimate procedure. It's just one that I don't favor for the reasons of I've seen many patients with problems with this. The whole thing of an office procedure is it shouldn't cause problems. It may not work. It only works 83% of the time, but there's some major problems that can happen with this. The sutures can migrate. Patients can be pretty unhappy. And so I've seen so many people that are unhappy with this and way fewer that are unhappy with Rezūm. So and the other thing is it leaves these foreign bodies in your prostate that cause trouble. So to me, I'm not a big fan of this procedure. Let's just put it that way. I think some of the lucrative nature of it had something to do with the adopting of it, but it is a legitimate office procedure. I'm going to I'm going to see if I can go further in this talk to get to some other things, because I'm on the subject of office procedures now. So there's another procedure called the ITIND. I think it's owned by Boston Scientific. It's a procedure I don't do. I don't think it makes much sense. It's sort of, you have your go-to. What the ITIND is sort of a cage that's opened in your prostate, and then the two wires down below here kind of gently with pressure kind of make these two cuts in your prostate over time. You have to leave it in, you have to have it extracted. It doesn't really work better than these other procedures. So for me, this is not a good procedure. I will point out that there's in development several prostatic urethral stents that are excellent procedures, where they would be things that you open up and they can either be temporary or permanent. They don't kind of push through, and there's probably 4 different ones in development right now. So that's going to be the next area of minimally invasive office procedures. So those are, let's just call those the office procedures that I can talk to you about. There's something that's become very popular in those big private equity groups now that is suddenly embraced called prostate artery embolization. I'll get to that separately. And then if those are not going to work, so those procedures don't really burn any bridges. Those procedures are things you can try in the office. If they work, you're going to be very happy. Generally, they're going to give you about 5 years of saying I've peed great, and then just like a sink, the symptoms will start to slowly sneak back in. 5 years later or so, that's a good 5 years for 2 minutes. But if it doesn't work, or it returns, or there's more serious problems with your urinary tract, like stones, infections, don't empty my bladder, I couldn't urinate, I have a catheter in, then we oftentimes will do something that's more aggressive, and I call those operating room procedures. So now we're going to talk about operating room procedures. One procedure that I'm not a huge fan of, but it's out there, is called the GreenLight Laser. The GreenLight Laser is a device that also is heavily marketed as a minimally invasive procedure, but it has to be done under anesthesia. It was originally embraced like 10 years ago, 15 years ago, and it was because we used to always do what the gold standard treatment is called a TURP in the hospital, and we keep you overnight. And in the advent of people owning their own surgery centers, this laser was something we could do in a surgery center. So if you owned a surgery center, suddenly you could do something in your surgery center, which you'd rather do, and it was considered more of an outpatient procedure. The GreenLight Laser is very similar to what I'm going to talk about called the TURP. It's a laser that fires sideways, and it fires so hot it kind of bursts open the tissue and it creates a cavitary defect. The problem with the GreenLight Laser is eventually the tissue dries out, and the way it works is it bursts the water in the cells. So it'll stop penetrating after a certain point, and it creates a lot of necrotic tissue that tends to be very irritating and tends to bleed later. So I'm not at all a big fan of the GreenLight Laser. It doesn't work better than a TURP, which we're going to get to. It doesn't work nearly as well as a TURP. And now we usually do TURPs similarly in surgery centers as an outpatient. So that's on there for you to know about, but I'm not a big fan of it. I won't necessarily show you a video, but in essence, because I don't do it much, you put a fiber in here and it creates this cavitary defect as you see right here. Okay. And it's a good procedure, particularly for small prostates. But again, every procedure is good for small prostates. And generally, it's something that if I always view it as, if I'm going to put you to sleep and I'm going to do a more aggressive procedure beyond what I do in the office in 5 minutes, I'm generally thinking, why don't I do the procedure that works the best? And the procedure that works the best is called the TURP. The TURP and the GreenLight and most procedures done in the operating room, they work better. The TURP is going to work 97% of the time. It's like calling the plumber and he's going to snake your pipe. When he's done, that pipe is going to be open and you're going to flow great and everything's going to be good. That's the TURP. It has gone through several technological things. One of the good things about there always being a new hotshot treatment on the market that's minimally invasive is it puts pressure on the other procedures to become safer and safer and safer. So now we call this called a bipolar TURP. Previous TURP had to be done where we would run water through as we were cutting, but that water would get absorbed and cause complications. When it's bipolar, we can use saline, so it's safe. And now with bipolar, we have been able to do it so that we don't worry so much about bleeding like we used to. And it's in the advent of GreenLight Laser and all these other things done in the operating room has caused urologists to sort of say, what if we do TURPs as an outpatient? And it's caused us to be very comfortable to do that. So I can't remember the last person I kept overnight after a TURP. So that's also tends to be an outpatient procedure. Why, if it's 97% successful, why doesn't everyone choose it? Well, it has a higher risk, let's say, of things like scarring. It does have, and we're going to tell you that it has, it's probably not truly this high, certainly not this high in my series of patients, but we like to say it's a 1% risk of incontinence. So it's higher risk, higher reward. And that's why most of my patients are still going to say, I'd rather try the office thing. And if that doesn't work, I'll move on to the TURP. And that's generally what I do. So the TURP is kind of the gold standard. Okay. Now I'm going to use this slide where it says prostatectomy. I don't want that to be confused with a robotic prostatectomy or a radical prostatectomy, but I'd like to use this slide. This slide should say, what do you do if your prostate's really big? And we usually talk about grams. We generally think if it's greater than 100 grams, it's a big prostate. Sometimes they're 300, 400 grams, 200 grams is really big. And so what I always say is you get a different menu at the restaurant when you have a big prostate. When you have a really big prostate, the office procedures are not good choices for you. The GreenLight Laser is not a good choice for you because they're just not going to get rid of enough tissue. So the procedures, and I don't think I have separate slides for each of these, but the procedures that are going to be offered correctly for big prostates are a robotic simple prostatectomy. So, and that's videos on that on my site for sure. In essence, when you have a really big prostate, it's like having one of those big navel oranges from Whole Foods or one of those good ones with the thick peel where it's really easy to separate the peel from the pulp. Well, that's how your prostate is when it's really big. So if we can get in that plane between the peel and the pulp, you can very gently tease out the entire pulp intact and be left with this wide open prostate where you just urinate fantastically. And the two ways to do that are best are called a robotic simple prostatectomy. That's what I do because I happen to be very experienced with robotic surgery. There's a competing procedure that I don't do called a HoLEP, which is a laser procedure, but it's different than the GreenLight. Nothing wrong with HoLEP. At meetings, they always argue which is better, and there's no clear winner. There's pros and cons of each. What you'll find is that most urologists don't do either of those because either one of those is a very tough procedure to do that requires a lot of experience. And so one of the so if you're seeing somebody that does HoLEPs and you have a big prostate and you feel comfortable with that urologist, you should just go with that HoLEP. If you're seeing someone like me that says, well, let's do a robotic simple prostatectomy, then you should just do that. There's no ifs, ands, or buts. But what if you're seeing someone that really doesn't do either of those? Well, in that case, there's a third technology that's out there. I consider it not even close to the efficacy of the robotic simple or the HoLEP, but if one didn't do those tough procedures, the Aquablation was originally designed to fill that gap to say, well, that can handle big prostates. And I think there's a slide on that, so I'll get to it. And then they're starting to do also prostate artery embolization. I'm going to get to that as well. Both of those are procedures I don't favor at all. But just know that if you have a really big prostate, an office procedure is not the answer for you. There's too much tissue. A TURP is probably not the answer for you because it's too bloody to do that. And we're going to be picking from a different menu: HoLEP, robotic simple prostatectomy, aquablation, or prostate artery embolization. So what is aquablation? If any of you are old enough, and maybe you have some of the, you remember there used to be this flosser thing called a water pick, which was this like water jet going da, 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 da. Well, it's like 1,000 times stronger than that water jet. And it's basically an automated process where you set it up, and on an ultrasound, you tell it what you want it to blast, and it basically just destructs the tissue. The downside of it is it's very bloody. It's not nearly the efficacy of these other procedures. And so, since in my hands, I'm really good at robotic simple prostatectomy, there'd be no reason to subject my patients to the lesser efficacy and the higher hemorrhage rate of aquablation. But it's not a terrible procedure for it if you're seeing a practitioner that doesn't do these more advanced procedures. That's aquablation. They're starting to then say, well, let's try it on smaller prostates now. And that's where there can be a higher complication rate. Again, the marketing pitch of aquablation is they can say, well, we won't shave out, or we won't address the front of your prostate, which is where the seminal vesicles plug in, and we can try to save your ejaculatory function. Again, it's kind of like how UroLift needed to find a niche for things. So that is a possibility, but that generally means it's not resecting as well. It's not going to have the same long-term side effects. So I'm not a big fan of this. I tried to be, I got trained for it, but the hemorrhage rate was too high for me to accept. We've already talked about tuna as being a predecessor to Rezūm. And I guess there's not a separate slide here on, yeah, on prostate artery embolization, and it needs to be talked about. So let me give you the history of that. Don't know if anyone's heard about that. A prostate artery embolization is a procedure done by an interventional radiologist. And what it is like a Rezūm, or like anything, it doesn't cut anything. It is an invasive procedure that has risk. It's not like an office procedure. It shouldn't be thought of as a minimally invasive office procedure, but you're going to have basically an angiogram, so you have access to your vascular system, and they're going to snake a catheter all the way down to where the arteries feed your prostate, and they're going to plug them up and embolize those and try to decrease the blood flow to the prostate. And in so doing, it should kill some tissue and shrink it some. And that's the thought process. And it's been around for a long time. And for a long, long time, it was always very much rejected by urologists because it's way more invasive than the office procedures with not as good efficacy as the office procedures. So it was always rejected. But what's happened recently in the advent of, big, huge urology groups having 30 or 40 doctors, it's become a really an excellent thing that where they hire their own interventional radiologists and they suddenly own their own center for these things. And so they tend to kind of refer patients out for PAE, and you're seeing this explosion in popularity. Also, it's very lucrative. I can't help but point that out. But to me, I still have the same attitude towards it as the urologic community had towards it, say, 3 years ago, before groups started hiring their own interventional radiologists, which is it has more risk than a Rezūm or an office procedure without better efficacy. So for me, I'm not a big fan of that. I know some groups that say, well, what we're going to do is we're going to do a PAE in our center, and then we're going to do an aquablation, and that way it won't bleed as much. To me, that doesn't make any sense for a big prostate when you can just do a robotic simple. So that's PAE. So we're getting close to the end here. So hopefully now you understand that the treatment options in my practice at least are reassure you first, medicine second, then think about an office procedure, and then move on to a surgical procedure, meaning an operating room procedure where you're asleep if those things aren't working or if you have more serious problems. And obviously, I'm more than happy to talk to you. Just make an appointment with me. Go to my website first. You will learn a lot more there.